When saving lives is what you do, your standards are anything but standard. In fact, you set them higher than most to deliver results that patients can depend on. You refuse to compromise. We couldn't agree more. We are Edwards Life Sciences, and like you, we believe that good is never good enough. Rising to the challenge of today's TAVR patients isn't just a mission, it's a commitment. And because you set a higher standard, we set our sights on meeting you there. Welcome to the higher standard, your standard. Learn more at edwardstavr.com.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD from the Cleveland Clinic.
Hello, everyone. Welcome to the year-end finale of Parallax. And, like we have done over the past couple of years, this is year 3 of Parallax, so season 3. We've traditionally ended the season with Dr. Nijjer, who's a friend of mine, a colleague, interventional cardiologist, and senior clinical lecturer at Imperial College of London in the United Kingdom. And, we like this tradition. We like to maintain this tradition at Parallax because, I think of it as twofold. One, I think it's always good to not change the mantra if it's successful. And, Sukh's episodes have historically been the maximum downloaded episodes. So he does a terrific job in summarizing the year for us. And two, Parallax and Radcliffe are in the UK, Sukh is in UK. So I think it's sort of a good year-end episode to sort of be home in the Christmas spirit, in the holiday spirit, and, celebrate being home. So with that introduction, Sukh, welcome. And thank you for doing this for us again this year.
Thank you, Ankur. Thank you so much for inviting me back again. And with that introduction, I feel almost embarrassed and humbled to be speaking to you again.
Oh no, I mean, the listenership and the audience have always welcomed your input and take on the field and take on the trials that we're going to talk about. And the episodes where we've brought you on board and we've discussed this together have done really well. So congratulations to you. So we're going to get started because we have a lot to discuss and talk about. And Sukh has a great lineup for us in terms of antiplatelet studies, and then from antiplatelet studies he'll delve into some of the physiology studies on coronary physiology, and then we finish with heart failure and some of the surgical studies, from our surgical colleagues. So Sukh, thanks again for doing this, and we're going to dive right in. Why don't we start off with some of the antiplatelet studies that you've picked for us from 2021?
Yeah, sure thing, Ankur. Thank you for that. And I think it's a great opportunity to discuss some of the big antiplatelet studies that have come through. The world of antiplatelets has always been very confusing because there are a wealth of studies. They sometimes have conflicting results, and we don't always quite understand where we are with it. And it means that many people default back to very standard behaviors with the use of aspirin and clopidogrel. And then in acute coronary syndromes, we tend to go with the more potent PY2 receptor antagonists like ticagrelor or prasugrel. And this year, we've had a couple of studies that help clarify our understanding. And they can be divided into those that are looking at chronic coronary disease. So those patients who've got mostly stable disease that have had PCI, and we're trying to understand what antiplatelet these patients should be given long-term. And then there are those patients who are kind of more all-comers angioplasty, and then also the kind of more unique cohort of patients that we're all troubled with, and you and I will both have these patients on our books who are high bleeding risk patients. And so what I thought we'd start off with is just looking at the kind of more standard chronic coronary disease, stable coronary disease, or patients that have had PCI at some interval. And that was assessed in a Korean study called the Host Exam Study that was published at the beginning of the year and was presented in one of the major conferences at the beginning of the year. And it was interesting because it really builds on a signal of information that's been around for quite some time. So the basic premise of the study was to look at those patients that had had angioplasty, that had had aspirin and clopidogrel for between 6 months and a year, depending on the indication. So 1 year for ACS and 6 months for stable disease. And then what they did was they then randomized those patients to just continuing on aspirin alone or just getting clopidogrel alone. So in a way, it's an adaptation of this concept of prolonged DAPT, but rather than having aspirin in there, it's just clopidogrel. And so you could think that the clopidogrel is a more potent drug. This may well be advantageous. And they took around 5,500 patients, and they enrolled and randomized these patients with a very, very good rate of follow-up. And as you all know, there's been some excellent editorials on some of the weaknesses of the antiplatelet studies. Has been that loss to follow-up is actually quite high in many of these studies, and that can significantly impact on our interpretation, because in a few studies, the loss to follow-up can actually exceed the number of events that are even occurring in these studies. And what they did was they looked at patient-orientated outcomes. So they looked at a combination of all-cause deaths, non-fatal MI, stroke, and then readmission due to acute coronary syndrome, but also a bleeding endpoint, which is combined into that with major bleeding defined as BARC 3 and above. And what they found, surprisingly, is if you take this relatively stable cohort of patients that by definition have shown that they've not had major events or bleeding out to 1 year, had one of these problems occur in 7.7% on aspirin or 5.7% on clopidogrel, meaning that you had an absolute risk difference of around 2%. The hazard ratio was around 0.73, which means that you've got a 30% reduction of these major events just by getting rid of the aspirin. What's interesting is if you do a deep dive and look down at thrombotic events as well as bleeding events, they're all lower in the clopidogrel arm, and there's a lower level of stroke, and all the subgroups are very consistent. So this is an interesting study because remember, in the Far East and in the Far Eastern population, there are some genetic phenotypes. There's a CYP 2C19 variations, and there's a loss of function allele in the Far East, which means that theoretically in the Far East, clopidogrel may be less effective than it is in Western populations, because the second and the two-component cleavage that happens in the liver doesn't happen, and therefore this prodrug doesn't become active in those patients. And yet this study showed that in this essentially all-comers cohort of patients, they actually had a very good outcome. And so this kind of tells us that in stable patients that haven't had bleeding events and they've had some interval from PCI, that if you want to drop an antiplatelet, then the antiplatelet to drop would be aspirin. And that fits in together with a lot of the information that's come out of studies like TWILIGHT that came out last year that suggested that aspirin perhaps adds less than we thought in the past. And so those chronic patients can probably be managed on clopidogrel long term. And what's interesting about this study is that it essentially alludes back to a study from the 1990s called Capri, which is really quite old now, that had shown some benefit in patients with atherosclerosis who were given clopidogrel instead of aspirin, and there was a signal of benefit there. So I think that can help what we do in the management of these chronic patients. So particularly if maybe you've done intervention in the proximal vessel, or you've done bifurcation intervention, you may think, well, actually, I want to continue this patient on a stronger antiplatelet to reduce their long-term events. And therefore, clopidogrel may well be a safe use rather than dropping it as we do typically here. Certainly here in the UK, it's almost programmed into all primary care services. Primary care physicians will automatically stop the clopidogrel very, very quickly as soon as you hit that 1 year mark after their intervention. And so it will require a little bit of kind of education, retraining, and perhaps making it very clear to the patient that, look, you know, for you, I'd like you to continue the clopidogrel. Obviously, in this particular study, all the patients have been seen and reassessed. So that's something that, we'll have to work into our programs to be able to do that, which is something that's not done very much in the UK, but I know in the US that's relatively straightforward. Is this something that you do, Ankur? Do you tend to continue clopidogrel, or do you tend to go long-term DAPT on a lot of patients?
So, great question, and it was something I wanted you to summarize after we're done finishing talking about all the antiplatelet studies. But, my practice is that, for me, I think about it in the spectrum of acute coronary syndrome and then in the spectrum of stable coronary disease. If it's in the spectrum of acute coronary syndrome, I would definitely do at least 3 months DAPT. Now, we can talk about whether it's ticagrelor or clopidogrel. I prefer ticagrelor because of reduction in thrombotic events. And then after 3 months, I actually, depending on the bleeding profile of the patient, could do ticagrelor monotherapy. We have data on that. And then post 1 year, the question is whether I should put them back to aspirin monotherapy or clopidogrel monotherapy. And, after what we've seen published this year and, apropos the discussion we just had, I'm leaning toward clopidogrel monotherapy as, a chronic therapy in patients with chronic coronary syndromes. That's been a shift in my own practice. I don't know if you would agree or concur with that shift, but, I sort of think about these patients, particularly the ACS patients. I think about them in the spectrum of, okay, is it post 1 to 3 month PCI, post 3 to 12 month PCI, and then post 12 month PCI. And, these are the 3 time point intervals that I think about them. And depending on their bleeding profile, first 3 months, it's aspirin and a P2Y12. Then 3 to 12 months, it's a P2Y12 monotherapy for me at least. And then post 12 months, I think I'm probably leaning toward P2Y12 monotherapy. What do you think about that?
Yeah, I agree with you completely. I think, again, you have to look at the patient. You have to look at their bleeding risk. You have to look at the clinical situation. Is this stable? Is this an acute coronary syndrome? Is there been a big troponin rise? What's the coronary anatomy look like? And what's the risk of future events? And then you have to balance it. So it's a lot of juggling that you have to do. And I think we've evolved to a stage where we are really trying to give targeted therapy, which is individualized to the patient. And I know that people in the past have done a lot of platelet testing, platelet function testing. People have done genotype testing. Funny enough, genotype testing seems to be a little bit more effective in the studies than platelet function. And as far as I'm aware, none of the platelet function testing studies have ever come to fruition, whereas the genotype testing and escalation of antiplatelets based on genotype appears to be a little bit better, but we don't really have ready access to that. So I would follow very much what you do in the majority of my patients. And certainly now I'm frequently recommending, when the patients have gone through their highest risk period and they're getting to the end of when we're stopping the potent agents like ticagrelor or prasugrel, then I would typically de-escalate down to clopidogrel. And I think there is value to that. Certainly from a cost basis, obviously clopidogrel is an off-patent medication that's now very cheap, very easily available. Certainly before, it was always very expensive, and people were very keen to stop it. But that's no longer an issue.
Absolutely. Okay, so moving on, what is the next study you want to talk about in this space?
Yeah, so I thought this next study was very interesting because the next study is STOPDAPT-2 ACS, which is, again, a study performed in the Far East. And it was presented this year at the European Society of Cardiology in 2021. And it was a follow-on study from the STOPDAPT-2 study that was presented at ACC 2019. And what STOPDAPT-2 had shown was that actually going with a short duration dual antiplatelet therapy versus a full 12-month in an all-comer cohort seemed to be superior than going with a long period. So minimizing the time that the patient is exposed to dual antiplatelet therapy appeared to be superior. Now, this was in an all-comers cohort, and it appeared to be superior for ischemic events, but it was also lumped together with, the primary outcome was lumped together with bleeding events as well. So this kind of patient-orientated outcome that is frequently used in these type of studies now, combination of death, MI, stent thrombosis, stroke, and bleeding, appeared to be better by shortening the dual antiplatelet therapy. Now, what they wanted to do was do a much larger study focusing specifically on those patients with acute coronary syndrome, because we know that those patients are at highest risk, and they took those patients with ACS, and what they wanted to do is give them both drugs for 1 month, and then give them clopidogrel alone and drop the aspirin. But what was interesting is in this cohort of patients, dropping the aspirin early did not appear to be safe. And it certainly wasn't non-inferior. It didn't meet the non-inferiority parameters, which were pre-specified. And so therefore we can say that this pathway of dropping aspirin early in acute coronary syndrome patients is probably not safe. Now, the total number of events, again, in these studies, this is an example of just how good patient management of acute coronary syndromes is now. The total number of events is really small, and we're talking about a primary outcome occurring as 3.2% in the 1 month dual antiplatelet therapy versus 2.8% in those patients having 12 months of dual antiplatelet therapy. And you can start to think, was there enough power in the study? Did we have enough patient in the study? But what is striking here is in those patients that have had an acute coronary syndrome, I think what this tells us is that we really got to continue the aspirin for as long as we possibly can. Now, what you were talking about just recently was about the going with ticagrelor monotherapy, which perhaps is slightly different with clopidogrel monotherapy, and so we're going to potentially get a little bit confused here. But what STOPDAPT-2 ACS tells us is that clopidogrel on its own, straight after an acute coronary syndrome, probably isn't good enough, and therefore you may err on the side of giving something more potent like ticagrelor, which appeared to be safe in global leaders and in TWILIGHT. You have to be a little bit cautious, though, because remember, both in global leaders and in TWILIGHT, there was a different set of patients that have been recruited. These were not classical all-comers. TWILIGHT had a higher bleeding risk cohort of patients by the definition that the authors, Roxana Marianne's group, used, and there can be an argument over how high bleeding risk they really were. And global leaders had its own very special process of recruiting patients. So perhaps these studies don't translate, but what I took away from this was that we've got to be careful about stopping aspirin too early. What does that make you think about the process of stopping it early in your cohort of patients?
Yeah, so I think, in an ACS setting, like I said, I err on the side of continuing aspirin for at least 3 months. That's my practice. I tend not to stop it early. Even in patients who, and I know we're talking antiplatelets here, but a lot of our patients also have concomitant atrial fibrillation and are on anticoagulants. So even in patients with direct oral anticoagulants for stroke prevention in atrial fibrillation, my practice, at least in those patients, also at least for a month, is continue triple therapy. And, then I stop aspirin. I'm comfortable with them being on dual antithrombotic therapy is how I call it. So it's a combination of antiplatelet and an anticoagulant, P2Y12 and either apixaban or Isrivaroxaban. And then I continue that for at least, P2Y12 for at least a year. And then the question is whether they should be completely off antiplatelets and only be on DOACs or anticoagulants, or we should add a lower potency P2Y12 like clopidogrel for stable disease. But, in ACS patients, I err on the side of continuing aspirin at least for 3 months. And that's when I feel comfortable stopping it.
Yeah, I think that's probably a good strategy. The way I would do it in those patients, excluding those patients with concomitant atrial fibrillation, I generally keep them on the aspirin I probably go for the full 12 months. But that's because this is UK practice is very much guided by what our general practitioners, our primary care physicians are used to, and making those tweaks can be difficult. And funny enough, as I'm sure you probably find, there are patients where we've told them they can stop the aspirin, and then you may catch up with them at some later date and they're still taking it because a pharmacist somewhere or a primary care physician or a nurse, someone say, oh, you must continue aspirin. And so they've ended up never stopping it. So, even in the best, well-played, planned intentions, sometimes doesn't always come to fruition. I agree with you in terms of those patients with atrial fibrillation, for sure. I think minimizing triple therapy is very important, and dual pathway approaches with a combination of a DOAC together with an antiplatelet is the right way to go. I generally err on the side of caution and give clopidogrel in those patients rather than ticagrelor or prasugrel, because the total number of patients in the big studies that looked at those, actually very few of those patients were on the more potent antiplatelets.
Excellent comments. And I do think that both ticagrelor, both dabigatran as well as apixaban, I believe even Rivaroxaban, have been studied with ticagrelor. They have been.
Yeah, they have been. Ticagrelor has featured in all of those studies, but the actual numbers is relatively modest. If you look at Pioneer, I think there were very few numbers. And I believe in the more recent apixaban study, I believe it was around 10% or 12%, if I'm correct. Forgive me if I've made an error there, but I think the total number of patients is relatively modest. And of course, if you've got a robust patient without a bleeding risk, I think then you're very safe. Obviously, in a smaller patient, for example, you've got a low body weight, perhaps an elderly lady who has low body weight, I think I would be a little bit cautious in the use of a potent PY2 receptor and 12, if I can say it, antagonist.
Yeah, no, I completely agree with all those excellent comments that you just made. All right, so moving on to an area of your expertise. I mean, you have a New England Journal of paper in this area, so talking about coronary physiology. You want to start off with flower MI and then move forward?
So let's talk about physiology. So, I mean, everyone will always expect me to talk about physiology, and this is certainly something that I've spent a lot of my time working on and thinking about. And, if we take a global view and look at it from a bird's eye, then 2021 was not a great year for physiology and physiological studies because there were lots of negative studies. And I can understand how many of the listeners will think, okay, well, actually the overall outcomes have not been great for fractional flow reserves. And so, has the era of physiology come to an end? And there's a whole bunch of studies. And the first was Flower, which was presented towards the beginning of the year at, I believe, at ACC. And what essentially that did was it tried to answer that tricky question of patients who've had an ST elevation myocardial infarction. As many of us will know, many patients, around 30 to 40% of STEMI patients, will have multivessel disease. And yes, we will treat the culprit because clearly that needs to be revascularized and needs to be opened. But what do you do with the non-culprit vessels? And there's been a variety of studies over the years. There was the PRAMI study and the culprit study around 5 or 6 years ago that showed that actually multivessel PCI appeared to be better. But there could be arguments about the validity of those studies. They were relatively unique patient cohorts. There were UK-centric ways of working in those patients. All those patients were UK and the centres were all UK. So there are some limitations with that. But then it was followed by a much more comprehensive study, the COMPLETE study, which was predominantly North American. And that had showed a fairly clear picture that complete revascularization with intervention to all lesions that were considered significant angiographically proved to be better. But again, most of the events were driven by reduced revascularization. And so there is still always a little bit of doubt. Now, along parallel to that has been this question of, can physiology help guide that? And there were some studies, again, a few years ago that looked at this Dynami-3 Primulti, and there was Compare Acute, that used fractional flow reserve either at the time of the STEMI or as an inpatient after the patient has had their STEMI. They've had it revascularized, and a couple of days later they'd have FFR. But what those studies did was they compared it to no revascularization at all. Okay, so that means if you were randomized to the FFR arm, you got multivessel PCI often, But if you were in the other arm, you got nothing. And unsurprisingly, there was a big separation in the curves, and the Kaplan-Meiers separate quite dramatically. But they were limited because they weren't blinded. Naturally, if you've revascularized everything, then interventionists tend not to bring patients back unnecessarily to perform further PCI. And so much of the events were driven by non-urgent revascularization. So that comes to the current study, and that's Flower. And what Flower did was try to answer this question by saying, look, why don't we measure fractional flow reserve in all the vessels in patients with multivessel disease undergoing a STEMI at the time of the original PCI. And what they did was they randomized around 1,200 patients, so it's 1,171 in total. And that worked out as around 600 patients in each arm. So what they looked at was death, MI, or urgent revasc. And what they found in this particular cohort in Flower MI was there was no difference at all. And so the value was 5.5 versus 4.2% in either arm, when the p-value was non-significant at 0.31. And there were no significant values in non-fatal MI, and there were no significant differences in urgent revasc as well. And so that kind of led to this feeling that perhaps using fractional flow reserve in this cohort of patients perhaps wasn't very good. And if you then actually do a deep dive, you can start to see that the hazard ratio actually looked unfavorable for fractional flow reserve, with a hazard ratio of 1.32, implying harm in those patients that have had an FFR measured, which led to people saying, look, in this cohort of patients, FFR is missing things. But there are some limitations to the study. And whilst it does add to the literature, it does help us gain more understanding, there are some limitations. The total event rate in this relatively small study is very small. There are literally only 32 events in the FFR group, 24 events in the angiogram group. And so we're talking about a difference of 8 patients driving all of the events in this particular study. And I don't know about you, but I wouldn't necessarily base the management of all my patients going forward on 8 patients. And so there is a limitation there. We also know that the study was stopped relatively early, which caused some loss of power. And I think there is also some recognition now that we've got to be a bit careful with fractional flow reserve in the STEMI cohort, because when we give medicines like adenosine in order to induce hyperemia, there is a blunting of the hyperemic response. So in patients who've had an MI, an acute MI, will have essentially maximal vasodilatation of their microcirculation at rest, and they will be in a very disordered state in that moment. Their microcirculation is often affected by thrombus and distal embolization, and there is also histopathological studies that show that there is blebbing and microblebbing of the microcirculation, which also leads to problems. And so that may mean you underestimate the fractional flow reserve in a value. So by that, I mean you may measure a negative FFR value, one above 0.80, and therefore you may inappropriately defer a lesion that would have otherwise been stented. And then there is also the fundamental issue about fractional flow reserve in acute coronary syndromes, because I think there is increasing recognition that fractional flow reserve's original validation, its original work to bring it to its utility, the way we use it now, was in stable cohort of patients. And patients with acute coronary syndrome tend to have angry plaque. They tend to have multiple plaque rupture in multiple different vessels. And this has been shown by histopathological studies. And I think in this particular setting, the feeling is that if we pacify the plaque, then we will reduce events. Now, I would push back a little bit on that, because I think that still remains to be proven. I think there is some interesting unique data, and I know Greg Stone is pushing very hard in this field, and there is a push for looking for vulnerable plaque, however you define it, whichever imaging technology you use to look at it. But and I think that's still to be proven. But I would just express a little bit of caution in the use of fractional flow reserve, particularly when it's negative or borderline negative in the STEMI cohort. But I wouldn't necessarily stop doing fractional flow reserve on the back of Flower MI. And also, it's probably just worth pointing out that although kind of people looked at this as this was, a negative study. This is actually in keeping with a lot of the previous FFR studies performed in acute coronary syndromes. And there's a wealth of observational studies and cohort papers that have come out of the US principally, looking at FFR measured in acute coronary syndromes. And the signal has always been the same. That is, the event rate has always been higher in ACS patients, and deferred lesions on the back of FFR have always had a higher event rate. So have caution when using this technology in that cohort of patients. Is this something that you do, Ankur? Is this something that you ever measure, or is it something that you would typically rest a patient on the ward and bring them back for revasc on the back of complete, or what's your practice in your centre?
So the latter, I agree with you. I tend not to do fractional flow reserve or instantaneous wave-free ratio assessments in patients who are being admitted or presented to the cath lab with an acute coronary syndrome. Like you said, this technology of coronary physiology assessment was, I think, it's been validated, don't get me wrong, it's been validated in patients with acute coronary syndrome, but I think it was traditionally meant to assess, stable disease and, the physiological significance of stable lesions. And because of vasospasm, cytokine storm, and inflammatory milieu, what have you, unstable angry plaques everywhere in the setting of an acute coronary syndrome, I'm not sure if I would hang my hat a lot on either a negative or a positive, physiological assessment of a lesion which appears indeterminate to the eye.
Yeah, and do you image in this cohort? So, say for example, you've done a proximal LED. The patient had a relatively short occlusion time. The patient's quite well. There's a tight circumflex. Would you automatically revascularize that patient in the same setting? Would you use imaging to guide your decision making? How would you guide it? Because the challenge often is in the STEMI cohort of patients is that many of these patients have had no symptoms and no angina until the day of the event. And many of these lesions have been present. And so you just wonder, what are we actually doing in that moment? Is this lesion a true vulnerable plaque? Is it a true unstable plaque? Or is it just a bystander lesion that we're now placing an additional piece of metal? It's a little bit difficult to know, isn't it? So I just wonder what you tend to do in this setting.
Yeah, and I couldn't agree with you more. I actually, not too long ago did send a tweet specifically asking that question to the community, and that is, under what circumstance does an ACS patient with a non-culprit lesion become, a courage patient? Just to put your question into perspective. And it's a concept I still battle with, as a practicing clinician. I'll tell you what I do in my practice. In my practice, if the culprit lesion door to balloon time was short and, I have the guide up and it's just a matter of putting a wire down the other vessel and fixing it. That's what I do, for patient convenience. If it's a longish procedure and, I have to switch guides and, I have to tackle another vessel, or if the lesion appears a little tricky, I tend to stage these lesions, but I don't typically either image. I mean, if they look angiographically severe or significant, I tend not to image them. I tend not to even do physiological assessment. I just stage these lesions. And, that's what I do now. Do I have the literature and data to support this practice? I do. Am I convinced if this is the most evidence-based practice of coronary revascularization? I'm not certain. There's equipoise in my mind. I don't know how else to put it.
Yeah, I would agree with you, Ankur. I think, there's a very fine point, and I think we get ourselves into a little bit of a mess when we say that we are performing everything with an evidence base, because the reality is most of the patients that we come across wouldn't not be randomized in a particular study because they may have an exclusion, they may have some complexity. The fact that when we're recruiting for apparently simple randomized control studies, that we end up screening and going through so many patients and to recruit one, just puts into my mind that actually a lot of the evidence that we hang our hats on or say, we're doing it because of this study, and this is the study that will guide all of our practice, actually kind of makes it a little bit of a mockery of it. And part of being a doctor, part of being a physician, part of being an interventionist is trying to meld that information that comes in trials, trying to meld that with the clinical guidance, and of which guidelines and guidance are living documents that will evolve over time, and they have their own biases, and they can be controversial, just like the new update on revascularization. I can see on Twitter there's a lot of controversy from our surgical friends who feel hard done by. And then there's also marrying up what the expectations of the patient are, because of course they're the most important person in this conversation and what they would like us to do, plus also the limitations of the health system that we work in and the constraints and the way that things work in your particular department, and whether we accept this or not. What would our colleagues say about the way we've tackled a particular issue? What would our non-interventional colleagues say? And certainly we tend to have a very conservative view in the UK. I know there are many bloggers and podcasters that like to say that they're conservative cardiologists, and I know this has become a bit of a brand. Personally, I think that actually in the UK, we are almost always relatively conservative compared to what we see in other countries, certainly compared to mainland Europe, and compared to, we do a lot of high risk stuff, no doubt. We do a lot of complex lesions, no doubt. But the way the timelines work in the UK is that we're relatively conservative already, because it takes time for patients to come through. It takes time for testing. And so actually all of that is being weighed in your mind while you're trying to make this decision at 4 a.m. about whether you should tackle that circumflex. And so I don't want to criticize anyone who decides, I'm going to stage this. I'm going to bring this patient back, or, I'm going to see the patient in clinic, in the office, see if they're still having any symptoms. And if there are symptoms, then maybe we'll do it. And if there's not, and I think there isn't a hard and fast rule for any of these things. You've got to use your gut instinct. And that gut instinct comes over many years and over many, and it gets honed with time. And I always say this to a lot of my colleagues, because I've been at Imperial for a very long time. I was a trainee there and now an attending there. And so what we do now, I would say none of the people who trained me were doing on a routine basis just a few years ago. So the way that practice has evolved is so dramatically different. And I imagine what I'll be doing in 5 and 10 years will be very different still. And I imagine what the trainees that are coming through now are looking at and worrying about and trying to get into their heads will also be very different as well. And the way that we practice will evolve. And so there's almost no point in fighting it. And we just have to kind of roll with it and just say, look, our practice is going to change. We're never going to be perfectly right. We're going to try and bring the data that we have and understanding that we have and apply it to the patient in front of us. And that's really the challenging aspect of medicine. That's kind of what makes it exciting, right? That's that balancing game. I don't know. I mean, this is a philosophical debate rather than a data debate. I don't know what your thoughts are on that.
No, I agree with you. I think at the end of the day, we are treating the patient, and we're treating the person behind the patient, and there are many factors. Just like you said, is this person going to be adherent and compliant and show up in the next office visit? Is it safe to just stent this now versus stage this? Is he or she adherent or compliant with dual antiplatelet therapy? Do I need to put more metal until I am convinced that this patient is going to take dual antiplatelet therapy as prescribed? What is the financial situation? What is the social situation of this particular patient?
Yes.
Many scenarios, which, interface with evidence and data play into decision making. And it's just not all about, randomized clinical trials and evidence and data. I mean, we're dealing with patients, and patients have, there are barriers, and, that as swiftly as you and I want to solve them, there are system issues into procuring medicines, access to, healthcare, and access to affordable medications, particularly in the US, is a vexing problem. And
yeah, I mean, this is the ironic thing that, we can butt heads, and you'll see these interesting discussions of people arguing over a 1 or 2% difference, or a troponin difference post-surgery, or troponin difference post-PCI. And the reality is, you're worried about a little bit of apposition here, or an OCT, or a little bit of expansion here. But the reality is the patient doesn't take their clopidogrel because they can't afford the copay in the US, and so they're non-adherent, as you would say, and they can't take the drug, and therefore they have all the bad complications of that kind of system issue. And that's a much harder thing for people to tackle. Certainly here in the UK, we have a socialized healthcare system, which has some downsides, no doubt. It does have a huge benefit. I almost never have to consider, is the patient going to be able to afford to take these medications as part of my decision making? But that doesn't necessarily mean that all of those thoughts go out of our head, because of course there are other constraints within our services. So I think every place has to tackle all of those particular issues. And I know you've had some experience of working in India, and when I hear some of the stories from my colleagues who work there, and they really troublesome stories of patients who cannot afford to have the treatment that they really, really need, and so having to choose lower quality treatments or no treatment at all. And that when you hear these stories, it just makes you despair, really, about how we've allowed this kind of system to exist around the world, this inequality.
Yeah, I couldn't agree with you more. It's more of a problem I've seen it in the US, I've seen it in India, people have opinions of NHS, but NHS has been shown to work and has equitable disposition of care, as you just mentioned. Whether that system can work in the US or in India, only time will tell. But moving forward with some of the other studies in physiology.
Yeah, let me mention, so we are a philosophical tangent there. So let me mention Ripcord II. And I think Ripcord II is an interesting study, not least because it was done by our president of the British Society of Intervention, Professor Nick Curzon, but also because it is interesting for us, particularly Imperial, where we are one of the highest users of pressure-wise in the country. We keep being told by the various companies that our usage is much higher than everywhere else. And what Ripcord II looked at was a riff off the original Ripcord study, which used pressure wire assessment to see if it altered decision-making. What they did was they measured fractional flow reserve in every single vessel that had a narrowing of more than 30%. And then they looked to see if there was a difference in decision-making amongst physicians caring for the patient, and a difference in cost, and a difference in quality of life. And this was done at the diagnostic angiography stage. So this is quite different from how many centers use FFR. This was done at the diagnostic stage. And this is how we actually at Imperial use fractional flow reserve. We will measure it during a routine diagnostic cath. Every patient will be consented for the use of physiology and imaging for us to truly understand what the coronary disease is, and to decide whether it's appropriate. This is in the stable cohort, of course, whether it's appropriate for them to come back for revascularization in another setting, depending on how they've been booked. And so this is perhaps a slightly different use of physiology, how many other people use it. So remember, much of the use of physiology is in the context of, we've decided to place some stent, we're looking at multivessel disease, we think that we need to do the LAD, but we're also going to assess the circumflex and the right coronary artery. So slightly different use. And in this, around 1,000 patients, so it's 1,100 patients, that means it's relatively small, perhaps not quite powered for hard outcomes in this study, showed that actually there was no significant difference in the quality of life of patients. And there was no significant difference in the cost in the management of these patients. What's interesting is that by using FFR in this diagnostic way, the patients who were randomized in that cohort of patients had a lot less tests. So they didn't have that thing that sometimes happens in the UK, which I've always thought was a little bit crazy. So you come for an angiogram, which I think of as a end goal after multiple other tests. But in lots of hospitals and lots of centres, people will do an angiogram and go, oh, well, there's a narrowing there and I don't quite know what to do. So now I'm going to send them for an MRI, stress perfusion MRI, or now I'm going to send them for a stress echo. And I kind of think that's backwards. And sure enough, in this study, they showed that if you do an FFR up front, you reduce the total number of tests done. But interestingly, because of the cost of the pressure wire and the adenosine, and perhaps the additional cost of guiding catheters and along those lines, overall, it was cost neutral. Now, what's remarkable is that actually they're able to manage these patients. These are all patients who are being referred through what's known as a rapid access chest pain clinic, which is UK listeners will be very familiar with. They're able to manage all of these patients on average for a cost of £4,500. Now, I don't know what our US listeners think about that, but that's an incredibly low cost of money, low sum of money to be able to manage patients who are undergoing invasive procedures, pressure wire, and all these kind of things. So, you know, just to tantalize our American cousins here to think that we can do things at such low cost here in the UK and still at high volume. But what was interesting is that it didn't really make any difference. So there are some limitations to this study. I think it's a nice idea, and I think the concept was a good idea. But it led to this kind of concept. I saw this in the press, people saying, oh, well, this basically tells us that fractional flow reserve is negative in flower, it's negative in Ripcord II, therefore what value is it? And I'd say that perhaps this was using the technology a bit beyond in the way it was meant to be used. And perhaps if you're assessing a lot of very mild lesions, it probably doesn't add anything in that cohort to patients. So I thought that was interesting. I think it's worth mentioning that because it kind of led to the overall negativity. And then I'll just move on to the kind of the big negative one that came out recently, which has kind of been perceived as a very negative study, which is the FAME-3 study that's literally just been presented by Bill Fearon. It's been published now in the New England Journal of Medicine. This is a very courageous, if I can use that word, study, and perhaps continues to show the hubris of interventional cardiologists that we still think we can take on coronary artery bypass surgery, CABG. And what they looked at was patients with multivessel disease, excluding left main, and they were randomized to an FFR-guided PCI approach or bypass, mostly driven by angiographic appearance. So FFR was not necessarily mandatory in that arm, although it was encouraged. Actually, the total number of patients who had FFR in that arm was actually relatively small. And what they showed in this cohort, in the 1 year data that's now been published, is that there was no significant advantage to PCI, and it was a non-inferiority study, and they were unable to meet the pre-specified definition of non-inferiority. So they've got the slightly farcical wording of that this was not non-inferior, so double negative, which some people would say, well, means that surgery is superior. I'd say that actually the study is not powered for that, and there are some limitations. There is a slightly higher death rate in the MI group, in the PCI group, which is slightly unusual. But there is a higher stroke rate in the surgical group, as we often know. And at 1 year, there is a slightly higher revasc rate in the PCI. And we know that if we perform PCI, we tend to follow these patients a lot more closely. We tend to bring patients back when patients have ongoing symptoms or have concerning issues. And certainly in mainland Europe, there is unfortunately this tendency to do top-up angioplasty. And I've seen Antonio Colombo talk about this. This was a problem when we were running Syntax 2, that centers would like to say, oh, we've just done a recath just to check if everything's all right. And I'm just going to give this stent an extra balloon. I don't quite understand what people think they're doing there, but that would count as a revascularization. So some issues there that cause limitation in the interpretation of the study. But I think ultimately what it boils down to is that perhaps we're kind of really at the edges of what we can do at the moment with multivessel PCI. And we're at the edges of what we can do if we don't necessarily do it properly. And I know there's been a lot of criticism on social media about the very low imaging rates. And certainly we touched on imaging a little bit earlier. And over the years, my imaging rate in intervention, just standard intervention, straightforward lesions, is now reaching to sort of 80, 90%, because the more imaging you do, the more you realize that you're just not getting it right. You're not getting the stent sizing right. You're not getting the expansion that you think you're getting. You're not getting the apposition that you think you're getting on the angiogram. So I would encourage everyone to use imaging where possible when you're guiding your intervention. I think it makes you a better interventionist. I don't think that if they had used IVUS to high levels in this study that it would suddenly match surgery. I think it's an unfair comparator. You're basically asking for a lot. You're basically asking for focal stenting to match a vein graft or a lima, which is basically covering all the vascular territory. And I think we should probably stop doing that comparison, because there are very different approaches to revascularization. And I think you and I will both have seen patients that have had bypass grafts, have had chest pain after, and this certainly happens in the UK. They have chest pain. They're seen by their primary care physician, or they're seen in an emergency department, and they go, and the physician looking after them will say, well, you've had bypass, so that's fine. And they're not investigated any further. And I don't know if you come across that. So my experience is actually, if you systematically perform CTCA in patients who've had recent bypass, the occlusion rate of a graft is actually pretty high. The German data suggests it's around 30% at 6 months. And certainly in my real world experience, I would say the same. It's around 30%. So actually, if we kind of looked into the bypass patients in the same way as we tend to follow our PCI patients, I think we would actually find that bypass hides a multitude of sins. Now, this isn't a criticism. This isn't a criticism of surgeons and their operations. I think this is a limitation of, the treatment, the technology. Just as there are limitations to stents, there will be limitations to bypass. The lima tends to stay. Unfortunately, veins tend to fail, particularly if you've got complex disease and the distal target isn't great. So, the reason I wanted to cover this is because it kind of completed the trifecta of negative FFR studies this year. And I can certainly see how a lot of people will be saying, you know what, it takes a lot of time. I don't think it helps. These studies are negative. I'm just not going to do it anymore. And I just wanted to highlight that there are limitations of these studies. Just in the same way as there are probably lack of power in flower, I suspect there's some limitation of power in FAME3. The event rate is not that high. I think they powered it for a slightly higher event rate. And so I think there are some constraints there. I don't know what your thoughts on this topic are, Ankur.
So I agree with you, Sukh. I think as years have gone by and, as more studies have been published and, obviously we have these conversations on social media about how low, particularly in FAME3, how low the imaging used was. I think, lack of routine imaging, intracoronary imaging in the setting of PCI in 2022, in my opinion, is suboptimal care. And I agree with you. It amazes you as to how deceptive just angiographic appearance of a well-expanded stent can be. And it sort of opens your eyes as to, how much more you can expand and oppose the stent, particularly with, intracoronary imaging. So I would encourage anyone and everyone who is an interventionalist who does PCI, as part of the clinical spectrum of duties and responsibilities to strongly consider intracoronary imaging as part of your armamentarium for just routine PCI. I think it's crucial for optimal stent results for your patients, and we have accruing data on how well these patients do if stents are well apposed and well expanded. So I couldn't agree with you more. I think with FFR, even with the publication of all of these studies, I'm not certain if it changes my practice, quite frankly. I was using it in assessment of lesions in patients with stable disease, and I think that's how I'm going to continue to use it. And I think based on some of these measurements, we do decide, because, more often than not, you'll see patients with multivessel disease. There's a tight circ lesion, which is mid to distal. There's a tight RCA lesion. And then you have this LAD, which you're not certain, it's diffusely diseased. You're not certain if it's significant or not significant. You end up doing physiological assessment, turns out to be significant. We do send these patients to surgery. So, it's great discussion and, some incredible points that you've raised and made. And I do think both these technologies, whether it's intracoronary imaging or whether it's physiological assessment of coronary stenosis, are here to stay. I think you just have to be mindful in picking these technologies for the right patient, as you mentioned?
Yeah, I think that they are all tools that are there to assist our decision making. They aren't. We should never. And this is something that we've taught for a long time on the physiology course in London. When people come to visit us and see how we think of it, we don't think of physiology as a hard go, no go, yes, no revascularization decision. These are continuous variables. There is nothing that has a hard straight line in biology and in the human body and in medicine. And therefore, if you've got a patient who's got classical symptoms, who's got ischemia testing that's been done, and that demonstrates that they've got ischemia, you've done an angiogram, they've got a stenosis. Sometimes we perform an FFR and it's negative, or we perform an IFR and it's negative. And then sometimes people say, oh, well, I'm just not doing it. Well, I would say that actually you've got multiple components of the story that suggest that there is ischemia. And if your value is, say, with an FFR of 0.81 or an IFR of 0.90, so just above the threshold, then actually you're in that zone where you could, on balance of probabilities, offer revascularization for the patient. Now, I'm not saying that in every case, but that's if you have that kind of combination of everything pushing you in that direction. And of course, you also have situations where, for example, you may have a patient that's got very atypical symptoms, doesn't sound like they're having angina. You've been pushed into performing an angiogram. Perhaps the patient's come on the table because someone else has driven the patient down to the lab, and you don't, the information that you've got before the cath lab doesn't imply that ischemia is a driver of the patient's symptomatology, and you don't think they're major in jeopardy. You do an angiogram, and sometimes there's very little disease. You move to show the patient doesn't have ischemia. You do an FFR, and sometimes it's strongly positive. And then that can surprise you, and that can suddenly make you pull out the imaging catheter, you assess it in more detail, and suddenly you understand that actually what you thought was trivial is actually quite significant. And that may alter your treatment. Alternatively, you may say, look, I understand that this value is positive, but I still don't think it's immediately needs revascularization. And in the stable cohort, you have the time to wait, get the patient on optimal medical therapy, see them back in clinic. And whilst people kind of look at FAME2 and say, look, all these patients needed to have revascularization because there was, particularly at 5 years, this big separation in the curves, I also say, well, just look at the other aspect of it. Because remember, in the arm that had medical therapy with a positive fractional flow reserve in FAME2, in the 1 year and 2 year outcomes, 75% of patients in that arm had no events. That means, majority of your patients will be absolutely fine to wait. And it gives you time to give them medical therapy and gives them time for you to escalate the treatment. And that's something that we learn all the time. I think we're learning to take our foot off the pedal a little bit with the stable patients and just be a little bit more relaxed in our approach to them. And I think the physiology helps it. If it's negative, it gives you a great deal of breathing space. If it's positive, it helps alter your the conversation that you have with patients. It helps alter your conversation you have with colleagues. Just like you mentioned just now, our surgeons will demand that we've done physiology in our patients. They will turn away patients who are referred for surgery if we haven't proven to the surgeon that there is ischemia there with a pressure wire. And that's because they've learned from us and they push us to make sure we do it. So sometimes we'll do an angiogram and go, oh, that's a no-brainer, definite for surgery. And they'll turn around and go, hang on, you haven't done a fractional flow, so you haven't measured an IFR. We're a big IFR lab, obviously, as being the originators of the technology. So they just expect that from us.
Yeah, well, a great discussion, Sukh. And I know it's getting late in the UK and we're a little over time for this segment. So probably going to have you back for part 2 for the 2021 finale, where we're going to cover, heart failure and surgical trials. And always terrific to have you, on board, because we have these discussions which are both evidence-based as well as, bedside. What do you do at the bedside? So thank you for, your in-depth knowledge and expertise, and we really value your contribution.
All right, it's an absolute pleasure to join you again, Ankur, and thank you very much for the kind invitation. I hope the listeners have found it useful. Yeah,
and, we're going to see you back shortly.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.